So here we're going to talk about the malignancies of the liver. If you haven't watched the section on the benign tumors, I suggest that you watch that one first, because this is going to kind of work off assumption of knowledge of the benign tumors. And it's also important because some of the benign tumors can degenerate into malignancies, and so it's good to kind of have that perspective as you think about the malignancies of the liver. So the malignancies we're going to talk about are going to be hepatocellular carcinoma, which is by far and away the #1 most common malignancy of the liver. Usually happens in alcohol cirrhotic patients, in patients with chronic hepatitis B or hepatitis C. We'll talk about hepatoblastoma, which is the #1 malignant liver tumor in children. The cholangiocarcinoma, which is technically not a neoplasm of the liver, it's a neoplasm of the bile duct, but it can happen in the very, very, very proximal bile ducts, which would be kind of like in the liver almost. So I wanted to talk about it here just for completion's sake. And then the hepatic angiosarcoma. So the anatomy of the liver, usually the left and right lobes by most people are divided up by the falciform ligament, this ligament traversing the liver right here. So you have your left lobe here and your right lobe here. Some people like to divide the liver up into which artery it gets its circulation from. So in that case, you have your hepatic artery here, and then your left hepatic artery and your right hepatic artery. The liver that gets circulation from the left hepatic artery would be everything left to the falciform ligament, and then part of the liver to the right of the falciform ligament. So if you want to think about it that way, then it is actually part of the right lobe would be considered the left. But for our intents and purposes, we're going to consider the right lobe to be on the right of the falciform ligament and the left to be on the left of the falciform ligament. As mentioned, the circulation into the liver comes from the hepatic artery, which is just a branch off of the celiac axis, and that splits off into left and right. You also get some supply from the portal vein. The portal vein is sort of your confluence of your mesenteric veins, superior and inferior, and your splenic vein, which come together and form your portal vein. And your portal vein divides up into, again, left and right. The drainage from the liver is the hepatic veins. That's going to be your left and right hepatic veins coming together and ultimately draining into the inferior vena cava. The biliary tract deserves some mentioning here, since we're going to talk about a tumor that affects the biliary tract. So we have our hepatic ducts, which drain bile from the liver. There's both a left and a right hepatic duct. They come together and form the common hepatic duct. So left hepatic, right hepatic come together, form common hepatic. That makes sense. That receives the cystic duct, which drains from your gallbladder. And when the cystic duct and the common hepatic duct come together, it forms the common biliary duct. So not the common hepatic duct, common biliary duct. Common biliary duct is your cystic duct plus your common hepatic duct. And then the common biliary duct progresses down and it receives the pancreatic duct. And once it's received the pancreatic duct, it's now the ampulla of Vater. And the ampulla of Vater drains into the second part of your duodenum, and the sphincter that controls that is the sphincter of Oddi. So in general, some principles to think about here. Most patients with malignancy of the liver will have right upper quadrant pain, as well as high liver enzymes, AST, ALT, sometimes alkaline phosphatase, as well as anemia. And anemia is sort of just a symptom of cancer in general. They can also have weight loss. So important to think about that. Your labs are usually going to be something that are provided to you on the USMLE because, well, if you're taking step 2, they'll be provided to you. If you're taking step 3, of course, you're going to have to remember, order a liver panel if the patient has right upper quadrant pain, duh. But your labs will give you a big hint that you've got something going on in the liver. Right upper quadrant pain is more often than not first followed by a right upper quadrant ultrasound, because one of the most common causes of right upper quadrant pain, as we know, is cholecystitis, and so we want to rule that out. But if you suspect a malignancy for any reason, especially if you don't see anything wrong with the biliary duct, or if you see a mass in the liver, which you usually do, you should always get a CT with contrast. That's going to help you diagnose your malignancy. In differentiating the type of malignancy, there's 4 different types here. The patient's history is of the utmost importance. Also important to differentiate these tumors from benign tumors. And achieving a cure for malignancies involving the liver and the biliary tract is always going to require a resection of some sort. However, not all patients will qualify for a resection, because a lot of patients, by the time we discover their liver tumors, are usually advanced in the stage. So hepatocellular carcinoma is the most common primary hepatic malignancy. Males are affected twice as often as women in the U.S., and the average age of onset is about 50 years old. So that's actually rather young, considering that this is, in most cases, an acquired malignancy. In most of the time in the U.S., it's a patient with long-standing cirrhosis, usually due to chronic alcoholism, possibly due to chronic hepatitis B or C infection. But these are generally patients where they have an established history that we know puts them at risk for developing hepatocellular carcinoma, so that when we see a mass in their liver, we're pretty sure we know what it is. They're not like the young female patients on oral contraceptives that we see a mass and we think, oh, maybe that's hepatocellular carcinoma. No, that's not what it is, obviously. So these are patients that have an established history of risk factors for hepatocellular carcinoma. Some of the other risk factors that aren't quite as common in the U.S. Are hemochromatosis. Schistosomiasis is a biggie because this is worldwide the #1 risk factor for hepatocellular carcinoma. It's just in the U.S. people don't get this. And then some environmental and occupational toxins include aflatoxin. So that's something that is found in hay, and so farmers can be exposed to that. Polyvinyl chloride is something that people can be exposed to occupationally. And then organochloride pesticides. Then Thoratrast is an old contrast agent that used to be used up until the 50s. And so we're starting to see the last of the patients who were exposed to Thoratrast. But that's an important one to remember in case it gets thrown out there. So most of the patients that were exposed to Thoratrast are in their 60s, 70s, 80s, or older. So this isn't as big a problem now as it may have been in the 1970s or 1980s when these patients were a little younger. Symptoms of hepatocellular carcinoma. So you're going to have the dull and achy right upper quadrant pain. Usually this has been going on for some time, but because it's so low grade and dull, the patient hasn't came in. This is not the same kind of sharp, unbearable pain that you might get in biliary colic or in cholecystitis. Other things that you can see are hepatomegaly. That would be a sign of just an enlarged tumor, possibly compressing onto the portal circulation. Tender abdominal mass, that could be the tumor, especially if it's closer to the serosa. And then you can also get jaundice. That would be if there's any compression of the biliary tract. And your typical symptoms of cancer, which would be malaise, fever, weight loss. Acute hemorrhage and shock presents in a minority of patients, but that can be a presentation of hepatocellular carcinoma. It usually isn't, though. Diagnosis. So remember, most of the time when patients come in with right upper quadrant pain, we're doing a sonogram, and you may suspect a hepatocellular carcinoma on sonogram because rather than seeing problems with the gallbladder or the biliary tract, you see a problem with the liver. The parenchyma of the liver, you see a mass. And so you can suspect it on sonogram. But the best initial test, when you really do suspect hepatocellular carcinoma, if it's based on sonogram or based on the patient's symptoms, would be CT with contrast. That's going to help us best see that this is indeed a tumor. Liver enzymes are going to be elevated, of course. That will be part of your initial workup. And alpha-fetoprotein, most importantly, is going to be elevated. That's the tumor marker for hepatocellular carcinoma. The most accurate test, and needed in some patients because they may have unusual presentations, is a biopsy. So if you're asked on the USMLE what the most accurate test is for HCC, it's a biopsy. And that pretty much goes for every kind of cancer. The biopsy is going to be your most accurate test. Remember, the only tumor that you cannot biopsy is the hemangioma of the liver, hepatic hemangioma, because they can bleed. So the treatment for HCC is ideally a resection. However, most of the time you're not going to be able to resect these because they're progressed too far. In that case, transplantation is the only hope of cure. There's no effective chemotherapy for HCC, so this is surgery only as a way to treat these patients. But most of the time, it's not amenable. Most of the time, patients, if they have HCC, they don't have long enough to live to make it on the transplant list. If it's resectable, the median survival is 3 to 4 years, with a 5-year survival of somewhere in the range of 40%. If it's not resectable, the mean survival is 4 months, so that doesn't give you really a long time on the transplantation list. And the operative mortality, even if you are going to try to resect or to transplant, is actually significant. It's about 1 in 20, 5%. And it's even higher if there's pre-existing liver disease, which there almost always is. So here's an ultrasound of hepatocellular carcinoma. This might be something that you would see if you were looking at their biliary ducts. And what you would see is this hypoechogenic mass. So compared to the rest of the liver parenchyma, this is blacker, hypoechogenic. Here's another one. This one's a lot more obvious. So here's your liver parenchyma, and here's your very well demarcated HCC. A Doppler ultrasound can help you. That with the hepatocellular carcinomas, there's rich vascularity within the tumor, and so that can help you with differentiation. CT with contrast will show you an enhanced tumor. So here's your enhanced mass right here. And here's another one. Okay, so the hepatoblastoma is the most common primary hepatic malignancy in children, and this usually presents within the first 3 years of life. Now, there's a correlation here, and this you've got to know. There's a correlation with Beckwith-Wiedemann syndrome, which, remember, Beckwith-Wiedemann syndrome is the pediatric syndrome that presents macroglossia, hemihypertrophy, so maybe one limb is bigger than the other, one side of the body is bigger than the other. Port wine stains, nevus flammeus, or those real big red birthmarks, abdominal wall defects, and then also they may have a history of when they were really, really babies, neonatal, they may have had some problems with their sugar levels, hypoglycemia. There's also a correlation with family history, so it wouldn't be in the child necessarily, but a correlation with a family history of familial adenomatous polyposis, and then also a family history, probably due to that, of early onset colon cancer. So that's these are some correlations that's really important to remember, but definitely the Beckwith-Wiedemann syndrome. That law can get thrown at you. Symptoms for hepatoblastoma are abdominal distension, failure to thrive, and jaundice. So not quite unlike what we saw in the infantile hepatic hemangioendothelioma, IHH. However, what you don't see so much with hepatoblastoma, you really shouldn't see, is the respiratory failure. Now, the reason that it can be difficult to differentiate a hepatoblastoma from an IHH is because sometimes the IHH won't have a really obvious, clinically apparent respiratory failure. So a lot of times the IHH and the hepatoblastoma are difficult to differentiate. And so in that case, you may need to get biopsy. So you may suspect hepatoblastoma on sonography. Obviously, you're going to get a sonogram on any child with abdominal distension, any neonate with abdominal distension. Best initial diagnostic test once you suspect it is a CT with contrast. If you get their lab work, liver enzymes are going to be elevated uniformly. Alpha-fetoprotein will also be elevated. Biopsy, of course, is the most accurate test as it is in any cancer. Differential diagnosis is going to be with, as mentioned, IHH. That is the most common benign malignancy in pediatrics. Usually this presents in neonates and newborns, whereas hepatoblastoma usually presents, it can present anytime within the first 3 years of life, but it can present after the first month. It could be 6 months, 8 months. Usually, though, it's within the first year of life. So hepatoblastoma oftentimes presents it can present after that first month, whereas IHH is generally restricted to that first month. So that's sort of some of the things that can help you with differentiating. Remember, like I said, the history and the demographics of the patient is really going to help you. Treatment for hepatoblastoma is resection and adjuvant chemotherapy. So we do both. We have to resect the lesion, and then we also have to provide chemotherapy, and the chemotherapy is cisplatin and doxorubicin. Cholangiocarcinoma is a malignancy of the bile duct epithelium, and about 5 to 30% of all the hepatobiliary malignancies are cholangiocarcinomas. Typically, this presents in older patients. Now, these risk factors are important to remember for cholangiocarcinoma because I can almost guarantee you that this will be part of the history in a USMLE question or part of the history in any patient with cholangiocarcinoma. These are important things to remember. So primary sclerosing cholangitis tends to happen in men who have ulcerative colitis. So either of these two, important to keep in mind. Choledochal cysts, a history of choledochal cysts, that can put you at risk for this. Caroli syndrome. Remember what Caroli syndrome is? It's an inherited dysplasia, but disformity of the biliary tract. So Caroli syndrome. And then infection with Pleurococcus sinensis. We don't see this in the U.S. This is more seen in Asia. Pleurococcus sinensis is a liver fluke that is found in underprepared, uncooked fish. So that's something that's more seen in Asia. And actually in Asia, they do have a higher rate of cholangiocarcinoma for that reason. The symptoms for cholangiocarcinoma are not that much different than what you see in hepatocellular carcinoma, other than in addition to this, we'll also see some really prominent signs of obstructive jaundice. And the reason is because this is a tumor that affects the bile ducts. And if you have the bile ducts with a tumor, you can get obstruction. You do have obstruction. So, of course, you have the dull, achy right upper quadrant pain, hepatomegaly, palpable abdominal mass, you can have that. But what you're also going to have is those prominent signs of obstructive jaundice. That's going to be pruritus because you've got a inflammatory reaction to the bilirubin that's getting into your skin. Dark urine because bilirubin is going into the kidneys, but whereas bilirubin not going, it's not going into your intestines. And so you're not going to get brown stool, you'll have clay-colored stool. And then, of course, your general signs of cancer, which would be malaise and weight loss. To differentiate, what we have to think about here are biliary strictures and cysts, cholelithiasis, which of course also presents with right upper quadrant pain, choledochal lithiasis, and pancreatic cancer. As we work up cholangiocarcinoma, all of these things are going to become really obvious when we do imaging. So we usually suspect cholangiocarcinoma. If we do sonography, you may suspect it if you see a mass in the biliary ducts. You may also suspect it based on the labs. What you'd see is an elevated alkaline phosphatase. Anytime there's a problem going on in your biliary ducts, alkaline phosphatase is your marker to think of, and vice versa. CT is another thing that will point us towards a tumor of the bile ducts rather than a tumor of the liver. And then ERCP is really the best test to do to diagnose cholangiocarcinoma because it gives us access to the bile ducts, physical access to the bile ducts to get a biopsy. Tumor marker for cholangiocarcinoma, and this is worth remembering, is CA19-9. This is also, I believe, a tumor marker for pancreatic cancer as well. The treatment for this is resection. The procedure you use is going to depend on the location, and usually these are not amenable to resection. By the time that you discover this, it's generally spread too much. The most common place for cholangiocarcinoma to present is, remember, right where the left and right hepatic ducts come together. So I guess that would be right here. It's most common for these cholangiocarcinomas to form right at that bifurcation, where left and right hepatic duct come together, and that's called a Klatskin's tumor. K-L-A-T-S-K-I-N-S. Klatskin's tumor. Okay. Like I said, though, this is usually not amenable to resection, but that's the only hope for a cure. Usually, this is palliative care, and it's a relatively poor prognosis. Hepatic angiosarcoma is a highly malignant tumor of the hepatic vessels, the vasculature of the liver. And the risk factors here are similar to what we see in hepatocellular carcinoma, minus the jaundice, or minus the sclerosis, and like the Okay, so hepatic angiosarcoma is a tumor of the hepatic vessels, the vasculature of the liver, and the risk factors for hepatic angiosarcoma are quite similar to what we see in for the risk factors for hepatocellular carcinoma, just minus the All right, so hepatic angiosarcoma, this is a highly malignant tumor of the hepatic vessels. So this is not a tumor of hepatocytes. This is a tumor of the vessel walls. And this is what we are concerned about in young patients with IHH. We're concerned about degeneration to angiosarcoma. The risk factors, apart from having IHH, basically include everything that you would see as a risk factor for hepatocellular carcinoma, the most common liver cancer, minus the cirrhosis. So you're not at risk for hepatic angiosarcoma because of alcoholic cirrhosis or hepatitis, I don't believe. Risk factors primarily are going to be your occupational exposure, vinyl chloride, arsenic, organochloric pesticides, thorotrast, and then some diseases, IHH, as we mentioned, neurofibromatosis 1 or von Recklinghausen disease, and then hemochromatosis. Symptoms of hepatic angiosarcoma are right upper quadrant pain. You can also see a hepatosplenomegaly. Ascites and jaundice are also seen. High output cardiac failure, remember, back to IHH. These are kind of similar in that you've got vessels here. So you can have a high output cardiac failure that can cause you to develop congestive heart failure-like symptoms, especially the pulmonary edema, difficulty breathing. You can also sometimes hear a hepatic bruit. For diagnosis, if you have a patient who's got these risk factors, anytime they have a mass, especially usually it's going to be diagnosed, the mass is going to be diagnosed on sonogram. It's going to be, again, useful to get a CT with contrast. But the ultimate gold standard diagnosis is with hepatic arteriography. Biopsy should be avoided here because this is a vessel disease. We usually want to avoid doing biopsy. And also because hepatic arteriography is such a great test to do for this. Resection is the only chance for a cure, but rarely is it possible. You can prolong survival, but you can't cure it with doxorubin and cyclophosphamide. So important to remember here, this isn't a very common hepatic tumor, but you do see it in children who have a history of IHH or in adults who have been exposed to these pesticides and chemicals. All right, now the most common malignancy of the liver is secondary malignancy, metastasis. And I think it's like 90% of tumors of the liver, cancerous tumors of the liver, are actually metastases, not primary hepatic tumors. In many instances, patients are asymptomatic until metastasis to the liver. And then at that point, what you're going to see is right upper quadrant pain and liver failure. So you may see jaundice, as well as some of the other symptoms characteristic of liver failure, asterixis, hepatic encephalopathy. The patient can also have the typical malignant history, which would be unintended weight loss, malaise, fatigue, fever. The most common tumor to metastasize to the liver is colon cancer. About 60 to 80% of when you have metastasis to the liver, 60 to 80% of them are colon cancer. Breast and lung are also common. You can also have pancreas, esophagus, and stomach too. Diagnosis is going to be CT or MRI. If you don't know what the primary tumor is, then colonoscopy can be useful, or a chest x-ray, or a mammogram, supposedly, if it's a woman. But usually the patient, you're going to know what their history is, what their cancer was. Maybe a patient who has had a history of colon cancer and now they have liver metastases. Remember your markers for colon cancer: carcinoembryonic antigen. So if the patient has had a history of colon cancer and now they have liver tumors, usually it's multiple liver tumors, maybe a good idea to get a CEA. You don't necessarily have to go in, do a colonoscopy. You can just get a carcinoembryonic antigen level. The treatment is going to be targeted on the underlying primary malignancy, usually chemotherapy for that. Unilobar malignancy often can be treated with a partial hepatectomy. However, if there's malignancy in both lobes, obviously you can't take both lobes out. So that's a no-no for resection. So here's a CT of metastasis to the liver, hypoechogenic. So here's one in your left lobe, and here's 3 of them in your right lobe. Maybe 2 others right here. There are several. And here are a lot. But they look like they're pretty much on the right lobe here. So possibly right. I don't know. I don't know if you could do if you could take the whole right lobe out. So I'm not a surgeon by practice, so I don't want to give you any bad advice. All right. Here's a gross specimen of metastasis to the liver. So lots and lots and lots. Usually with hepatocellular carcinoma, there's one broad focus. So to recap, hepatocellular carcinoma, generally the patient has a history of cirrhosis, alcoholism, or chronic hepatitis, schistosomiasis in the rest of the world, is the most common cause, hemochromatosis, aflatoxin, polyvinyl chloride exposure. Symptoms here, like most of these, are going to be dull and achy, right upper quadrant pain, hepatomegaly, abdominal mass, general symptoms of weight loss, fatigue, malaise. Diagnosis is going to be via CT, and elevated alpha-fetoprotein is your marker for hepatocellular carcinoma. Treatment is surgical resection or transplant. No chemotherapy here. Hepatoblastoma is in the very young children. Beckwith-Wiedemann syndrome is often in their history, family history, perhaps of FAP or of early colon cancer. That's colon cancer at a young age. Symptoms here are going to be abdominal mass and pain, failure to thrive, jaundice, fever, weight loss. Diagnosis here is going to be CT, elevated alpha-fetoprotein here as well, and then possibly you may need to get a biopsy to differentiate this from IHH. The treatment here is resection and chemotherapy, and that's with cisplatin and doxorubicin. As you see here, the symptoms are primarily the same for all of these. It's the history that's different. Cholangiocarcinoma usually has a history of primary sclerosing cholangitis, ulcerative colitis, which usually causes the primary sclerosing cholangitis, choledochocyst Crowley syndrome, and cholangiocarcinoma. Symptoms here are similar to the other ones: right upper quadrant pain, hepatomegaly, jaundice. You can also get dark urine and clay stools just because of the massive obstruction of the biliary tract. CT, CA19-9, ERCP is going to be your best test for diagnosis. It's going to help you get biopsy and visualize things. Treatment here is resection, usually bad outcome here too. Hepatic angiosarcoma, a lot of these patients have a history of IHH, especially if they're children. If they're adults, usually they have a history of exposure to polyvinyl chloride, arsenic, pesticides. Symptoms here, in similarity to the IHH, you can get high output heart failure. You can also get here jaundice, right upper quadrant pain, HSM, ascites, and weight loss. Diagnosis here is going to be CT with contrast and hepatic arteriography, which is going to help you visualize the angiosarcoma. Treatment here is going to be resection. Doxorubicin cyclophosphamide can prolong survival, but it is not curable. Resection is the only way to cure this, and again, this is usually a bad outcome. Secondary metastasis, history, usually cancer elsewhere, especially colon, lung, breast. Symptoms, again, like all of these, right upper quadrant pain, weight loss. Diagnosis is going to be via CT and various other labs that you can get based on what you suspect the original cancer to be.